would like to thank the Ocular emergency team for giving me this opportunity. My topic is an ocular emergency most commonly seen in our casualties, that is sixth nerve palsy. So, coming to the etiology of sixth nerve palsy, it can be broadly classified as congenital and acquired. Congenital causes mainly include birth trauma, hereditary causes, infection, failure of lateral rectus development, and Mobius syndrome, in which there is seventh nerve palsy accompanying the sixth nerve palsy. Acquired causes can be easily understood by looking at the course of sixth nerve. The sixth nerve originates from the pons at the level of facial colliculus and then travels through the petrous part of temporal bone. It lies in the medial wall of cavernous sinus and further passes through the annulus of Zinn to reach the lateral rectus. So, any lesions in the pons, in the fascicular area, in the temporal bone, cavernous sinus, or orbit can result into an acquired sixth nerve palsy. The common causes include trauma, space occupying lesion, infections, raised intracranial pressure, viral inflammations, multiple sclerosis, diabetes, ophthalmoplegic migraine, and cavernous sinus thrombosis. Abducens or the sixth nerve is the most common involved in cavernous sinus lesions because of its location in the medial wall. The four most common causes are idiopathic, hypertension, coexistent diabetes and hypertension, and trauma. Patient usually presents with acute onset horizontal diplopia, a history of underlying systemic condition, recent immunization, viral infections, and neurosurgery must be noted as they help to find the underlying cause. On examination, the head posture is usually on the ipsilateral side so as to prevent diplopia. The limitation of extraocular movements is seen on abduction. In acute cases, one can note past pointing, and diplopia charting shows maximum separation in the lateral gaze. Forced duction test is required to rule out any contracture in the antagonist muscle causing limitation of the abduction movements. Active force generation test is required while planning the surgery. Fundus evaluation is an important part of the workup of sixth nerve palsy and should be done to rule out papilledema and raised intracranial hypertension. The primary management includes investigations of neuroimaging, which should be done to rule out any space occupying lesion, demyelinating lesion, cavernous sinus thrombosis. Systemic investigations should be noted to rule out any underlying systemic conditions like diabetes, hypertension. The management is conservative and one should observe the patient for spontaneous recovery for at least 6 months. In the meantime, diplopia can be prevented either by using occlusion or opaque contact lenses, using injection of Botox in the medial rectus to prevent its contracture. For small deviations less than 14 prism diopter, one can use prisms also. Surgical intervention should be planned if there are no signs of recovery even after 6 months. The planning is done by doing a forced duction test first to rule out any contracture in the antagonist lateral of the lateral rectus, that is medial rectus muscle. If the forced injection test is positive or is tight, then first one should plan for a medial rectus recession. However, if the forced duction test is free, then active force generation test should be done to look for the tuck in the lateral rectus. If the tuck in the lateral rectus is present, then one can plan the resection of parietic muscle. However, if there is no tuck, then transposition surgeries should be planned. This is the list of further reading, and thank you.